Dr. Nirmal, please.
Yeah. Thank you, Dr. Sabyasachi, and thank you for the kind invitation. Am I audible?
Yes, sir. Yes, sir.
Good afternoon, friends. It's indeed a great pleasure to meet you all through this virtual All India Ophthalmic Conference. So my topic is on COVID and OT protocols, the NABH perspective. So this is my disclaimer. No financial disclosure. I work as a honorary principal assessor with NABH and passionate to improve the quality of eye care services. So why standards and protocols, and why should we base all these standards be based on NABH? Because so you should be beware of false knowledge that's more dangerous than ignorance. And COVID has surprised all of us. Unknown, uncertain. So amidst the uncertainty, one thing has remained constant, the rapid pace of change. So first wave, now we are suddenly looking forward the third wave, and we can be the first point of contact. Whatever variant come, ophthalmologists are at risk, and particularly dental and eye clinics are at risk. Hospitals have an obligation to keep their patients and staff safe, and we may face legal liability for the negligence. So it's important that we follow certain standards and protocol during COVID time. So this is the overview of protocol we should follow on, right from patient flow to the administrative controls, the infection control practices, manpower including staff health, the training and development of the manpower, and the logistical work, and the clinical management. And you can see the rapidly changing guidelines from the government and the various task force. So you should be updated on these protocols and standard operating procedure. So even though we are a small specialty that got involved in the COVID work, now with MUCAR in our mind, we should follow government regulations. And we should also follow the society guidelines and the standard treatment guidelines offered by All India Ophthalmic Society and various protocol issued then and there. It's high time we customize our OT SOP and update that with COVID protocols, because these keep changing. And don't copy from other institutions. So you can learn it easily and modify it to your needs. So this is our updated standard operating procedure, and in 24th June I updated till yesterday about the various issues with reference to infection control. The second aspect is screen your staff and patients for COVID symptoms. So this will help in minimizing the chances for exposure and risk to you and your staff. The third point is having a proper triage. So you need to manage visitor access to our IP areas and OT areas. And the fourth one is implement infection control. NABH has an elaborate infection control guidelines, one chapter fully dedicated to infection control. I'll come to that a bit later. The fifth one is implementing engineering controls. Ventilation is very important during COVID time, and barriers between the patient care areas. Dr. Subidhi has highlighted very well for the theater areas, the zoning, the various layout inside the operation theater. The sixth one, Dr. Samina has already highlighted very well, and train and educate personnel. These are new things, the COVID protocols and the requirements for our staff. So it's very important that we train and educate the personnel and also monitor them on a periodic basis. And we all know that it's people, not surfaces, that should be the main concern in this COVID era. So you have to have some eye on the natural ventilation for infection control in healthcare settings. We also need to appraise our people and staff about reducing talking in the OPD and OT because of the fear of aerosol generation and settling the virus in all places. And seventh is very important, establish reporting procedures. COVID-19 is a notifiable disease, and MUCAR being a new pandemic is again a notifiable disease. So if you come across such cases, you have to notify and report it to the government authorities. It's important from the medical legal point of view and also from the licensing point of view. Let me go to the OT protocols. that is the NABH perspective. So you have to update your OT protocols based on the guidelines and the various safety protocols issued after the COVID-19. And these are some of the general precautions you should take during COVID time and post-COVID. Preferably daycare procedures unless the medical condition mandate admission, and COVID testing by RT-PCR before all surgeries for at least for general surgeries and surgeries involving the lacrimal duct, it's mandatory. And avoid surgeries off hours. So recently, Sabyasachi mentioned a case. So during take all these high risk procedures or high comorbid conditions in the daytime, and see to that these are people handled by the senior surgeons. Bare minimum staff should be present when the patients are intubated, and two patients should be handled together, and leave some time in between the patients for ventilation and cleaning protocols to be followed. Try to avoid GA unless mandatory, and as mentioned, prefer topical over local anesthesia, and proper PPE, rationalized PPE for all staff. And there is a high risk of emergency during this COVID pandemic, post-vaccination as well as post-COVID. So high risk of embolism and cardiac disorders. So ensure that there is a system in place for a cardiopulmonary resuscitation. You also need to train your staff about the code blue. And you also need to focus on backup to make your OT safer because there is a long period in between various lockdown that we have not used the facilities. So you have to have alternate supply, and these critical systems have to be checked, particularly the fire system, electricity, water supply, medical gas, and the communication system. So these are some of the NABH standards highlighting the important aspect of infection control in the theater. And so this is about anesthesia. Dr. Samina has already told something about the administration of anesthesia. These are the overview of standard of requirement for anesthesia. There has to be a documented procedure. There have to be a pre-anesthesia assessment, and there has to be an anesthesia plan. Whether you have local anesthesia, conversion from peribulbar to retrobulbar, or from topical to peribulbar, you need to have an anesthesia plan. And GA versus LA, you have to select general anesthesia for certain cases, and topical based on the patient's comorbid conditions, patient anxiety, and also the surgeon's experience and preference. This is some of the way we handle things in our hospital, how we have implemented NABH standards. For general anesthesia, you need to have a surgical safety checklist. And since we have a good EMR, we are doing this online for children as well as people selected for general anesthesia. This is a simple way of taking care of the various requirements: adequate oxygen cylinders, anesthesia status, vaporizer status, breathing circuits, a laryngoscope, needles and syringes, emergency drugs, and any machine error in the chair. All our theater staff are trained for this. They check this every day. And if you are doing under general anesthesia or IV sedation, their post-anesthesia status have to be monitored, and the anesthesiologist apply a criteria to transfer and discharge the patients. You also need to monitor and report the adverse anesthesia events. So coming to the surgical standards, so COP, care of patients, this particular standards deals entirely with OT patients. You have to prepare the OT. You need based on your standard operating procedure. There has to be a system of monitoring and also proper system of documentation. We follow this daily checklist for OT, right from surgeons to various consumables and the equipment. So this is a small video. Not sure whether this will run. So just before starting the theater, I've seen many surgeons directly wash and go into the theater and start the surgery. So it's important that you go into the theater, do a proper inspection on various equipments, the table that has been prepared for the surgery, the various instruments, and also the emergency drugs for not only for general care, but also for ophthalmic emergencies during the surgery. So you just have to see this various area, and then you have to check the other zones, all those, particularly the CSST area, the washing area, the emergency drugs tray and all those things. So you also have to check the CSST, and also see to that you check the various indicators which have been used for sterilizing. And so overview of seeing whether the OT is ready or not include the intraocular lenses. And if there is it's a OT with AHU, there's no need for fumigation. Otherwise, in other areas, you have to check for fumigation register and see to that the autoclave registers are filled up and the first autoclave stickers are on. So prior to draping, you have to ensure that there is a timeout process. So we have to go through the operative checklist as well as the timeout process. So this is the overview of NABH standards for the surgical procedures. The patient has to have a pre-operative assessment. This is the online checklist we follow from antibiotic drops to general consent. And then the consent also for this is dynamic. So it's then and there it is filled up, and a consent is mandatory. We take 3 consents. So all these are checked before going to the theater. And this OTK sheet is also dynamic, check the IOL power calculation and various important procedures so that adverse events like wrong side, wrong patient, and wrong surgery doesn't happen. Prior to draping, we do the time-in procedure. So based on the patient name, age, address, operative eye, and lens implant, so we check the patient. So patient shifting and timeout in the OT, these are various steps. And then the operative note is documented prior to transfer out. The surgeon documents a post-operative care plan, and patient personnel and material flow, which has been highlighted by Dr. Subudhi on various infection control practices, and ensure that appropriate facilities and equipment are available in the operation theater. So this is the OT case sheet, including the type of IOL, type of surgery, and the various steps of the phacoemulsification procedure. And the IOL thing is again checked before insertion. So the operation notes is also dynamic, and it's done after the end of procedures. So after the surgery, you have to see to that safe usage of consumables and sharing of consumables happens, because we do use a lot of consumables for the procedure and share consumables between the patients. So there has to be some monitoring for this problem. So you have to ensure that the labels and stickers are stuck into the EMR or in the notes, and hard copies are scanned and digitalized. And once it is done, the discharge summary is generated in 5 minutes and given to the patients. So these, and you also have to ensure that proper biomedical segregation happens at source in all the areas of the operation theater. So to recap, standards and protocol help us to streamline the process for patient and staff safety. A well-designed checklist provides a strategy for dealing with complex emergency that can happen during any surgery, but also particularly during this COVID time and high-risk situation. So we can go beyond safety and beyond the checklist to ensure patient safety. Thank you so much for your kind attention. And if you have any queries, and this is one useful resource about accreditation of eye centers, Dr. Samina and some of my friends have been part of this initiative. You can go through. We'll be planning to bring the second edition soon. Thank you so much.
Thank you, sir. Thank you very much for this presentation, highlighting all the important aspects. I just want to have one question, sir. Which indicator you use, sir? Class 5. Sterilization indicator, autoclave indicator?
A class 5 indicator.
Yes.
We
So
use a 3M or 4S, and we use it for all the trays. So there is a double check indicator also.
So what will be our take-home message? So we advise everyone to use that class 5 indicator?
Yes, definitely. That is the advice. I advise people to use a class B autoclave so that class 5 indicators are useful, but it has to match your infrastructure. So in a vertical,
yes.
Yeah. So in a vertical autoclave, it's very difficult to reach the full stage of a class 5 integrator, class 5 or class 6 integrators. So you have to select your indicator as per your autoclave steam sterilizer equipment we use.
And for ETO, sir?
ETO is different. ETO indicators are available. We use that ETO chemical integrators.
So what's about AHU, sir? Whether everybody should have that or should not have that, or what is our What should be our carry-home message for this?
Right, it's a bit tricky questions. So AHU is, we have seen the usefulness of AHU in COVID situation, particularly safety with reference to the staff and surgical team. And also, since this is a aerosol producing procedure, many of us do aerosol producing procedure, and many of our movement, which also produce aerosol, high time we have air handling units in the theater for our safety, and also related to the infection control mechanism. I would advise a greater approach. So if you have seen the history of NABH implementation in India, 10 years back, there have been not many theaters which had AHU. Now, almost all the major hospitals and institutions have upgraded themselves to operation theaters with AHU, with single OT table and proper dedicated theater setup and layout. So this is a way to grow. I think small institution has a mind block as well as a resource block about going through this system, but it is a way to progress. So that is the reason the standards are starting from entry level, which is a certification program, to ICAS standard, which is an accreditation program. So we go, quality is cannot be achieved overnight. We have to go step by step.
Like some advice, having a dehumidifier with split OT can take care of temperature and humidity inside the OT.
So this HVAC system, heating, ventilation, and air conditioning system is a complex mechanism, right?
Okay.
So it comes under the engineering controls, and it is part of the National Building Code, which is a regulatory requirement, right? So if you have to change these systems, you have to change the regulatory requirement for public safety buildings, particularly hospitals. So this is not in our hands. The second thing is you have to understand the various, India is a diverse country. What works in one corner, like in a clean village-like atmosphere, may not work in a dusty, crowded place like our metropolis, Delhi, Mumbai, or Chennai, right? So you have to, rationalize these requirements. So the way forward is to try to implement all these engineering controls in a graded manner, particularly when you are building a new structure. So in a old structure, in a small facility, it will be very difficult to integrate these engineering standards. So there you can use this fan filter, a temporary arrangement like fan filter units, or using a dehumidifier. Dehumidifier gives perfect results for one particular aspect of engineering control, but it doesn't change or modify the entire air quality norms required as per